this scientific meeting. Ladies and gentlemen, this is a great honor for me that I can introduce Ádám Csirzó, who is exceptionally talented young researcher and clinician whom I have had the privilege to mentor. Ádám was born on the 7th of November in 1995 and completed his secondary education at János Garai High School in Szexárd. His passion for medicine led him to Semmelweis University's Faculty of Medicine, where he graduated in 2020 with highest honors. His dissertation, Flowmetry Examination of the Uterine Artery in Predicting of the Risk of Preeclampsia, which I had the honor to supervise, was recognized with an excellent grade. In 2022, Ádám joined to the Doctoral School of Molecular Medicine at Semmelweis University's Translational Medicine Center under my supervision. His PhD research, focusing on the medical and surgical treatment of endometriosis, reflects his dedication to advancing women's healthcare. Ádám has already contributed significantly to our field with two high-impact publications. The first one is a systematic review and network meta-analysis on medical treatment for endometriosis-related pain, published in the Journal of Clinical Medicine. This is a Q1 article. And the second one is a meta-analysis comparing robotic-assisted and conventional laparoscopy for endometriosis surgery, published in the Surgical Endoscopy. This is a D1 article. Since 2020, he has been an integral part of our clinical team at the Department of Obstetrics and Gynecology at Semmelweis University, where he excels as a resident doctor. He plays a key role in the care of patients with endometriosis, where his scientific research directly informs and enhances clinical practice. Additionally, Ádám is an active member of our clinic's robotic-assisted surgery team, performing surgeries under the leadership of Associated Professor István Szabó. In addition, he recently presented his research at the 19th Congress of Hungarian Society of Gynecologic Endoscopy in October 2024. I am confident that Ádám's contribution to research and patient care will continue to make lasting impact in our field. It's an honor to support his journey, and I am proud to present him today.
I warmly welcome everybody to my PhD defense. My name is Dr. Csirzó Ádám, and my PhD topic is medical and surgical treatment for endometriosis. I choose a huge topic, I know that, but you will see what we found. I'm a 50-year resident doctor in the Obstetrics and Gynecology clinic in Budapest. My supervisor is Sándor Valent, as you can see. I have a vision, which is endometriosis-related pain should be a concept of the past with one pill a day. And of course, I have a mission, which is to find the most effective pain relief therapy for endometriosis. Here you can see my two projects. The first investigated the surgical way to treat endometriosis, and the second one focused on the medical treatment. Let's start with the first one. Okay. Robot-assisted laparoscopy does not have demonstrable advantages over conventional laparoscopy in endometriosis surgery. It was a systematic review and meta-analysis. And my question is, has anyone ever seen a lady suffering similar? Who wouldn't want to help her? Of course we do. Endometriosis may very often be the cause behind this. So let's explore the background of it. Endometriosis carries a high individual and society cost. It's clear. We have a lot of available therapeutic options, for example, medical therapy, surgical interventions, and other non-medical management strategies. In this case, let's focus on surgical interventions. Nowadays, the gold standard therapy is the conventional laparoscopy, which is CL. But there's a newer, rapidly spreading technique, robot-assisted laparoscopy, REL. Of course, we have a third option, laparotomy, but nowadays it's just a rescue option if you have a serious complication in the previously mentioned two techniques. Okay. Then the question rightly arises, why is robot better? Here you can see a list about the robot-assisted techniques' advantages, but reduce pain, less blood loss, and so on and so on. But I would like to assume you with one sentence, we can say robot-assisted technique helps to make the recovery faster. But what is more important, do these advantages come out in practice in the field of endometriosis surgery? That's why our aim to compare REL and CL for the endometriosis surgery regarding perioperative outcomes. Our clinical question, is REL safer and more effective than CL in the field of endometriosis surgery? Our population, patients who underwent surgery for endometriosis, we compared the previously mentioned two techniques, and our outcomes were the different perioperative outcomes I will show you later. Our hypothesis, REL is superior, of course, to the CL in the field of endometriosis surgery. And after we finish this process, we can improve the surgical treatment for endometriosis. Here you can see our systematic search, our search numbers, a very simple search key. And after we finish the process, we got 13 eligible full texts. And the outcomes, the intraoperative complications, postoperative complications, operation room time, operative time, estimated blood loss, number of conversions, number of re-hospitalization, and the length of stay in the hospital. And to our surprise, we cannot achieve the results what we previously listed with numbers during our investigation. We cannot substantiate the result what we were expecting. We cannot substantiate the previously listed advantages with numbers. Moreover, between the two techniques, we did not find the difference excepting for one, and the result, surprisingly, the result in the particle aspect was unexpected, and that's what I bring to you. Operative time. And what we can see here, we measured the operative time from the skin incision to the wound closure in minutes. And what we can see here is an approximately 30 minutes longer operative time, not to the CL, rather than the REL, and this is not what we were expecting, as I mentioned. The background of this 30 minutes longer operative time is a kind of mixture of the docking time, the experience of the surgeon, and so on. Regarding to this outcome, I show you the quality assessment only of this outcome, and I would like to highlight you the most critical part was the distribution of the patients between the two techniques, and I will talk about later more. Our strength, the operation room time was a novel outcome compared to the previous studies. We had a long study period, and of course we have limitations. We got a lot of retrospective studies, and unfortunately we couldn't scale the severity of the endometriosis. We can't do any subgroup analysis regarding this. And as I mentioned, the patient selection was based on the availability of the robotic room and not randomized in the most of the cases. For endometriosis surgeries, REL does not have statistically demonstrable advantages over CL in the terms of perioperative outcomes. If somebody is a clinician, the clinicians love quick, short answers for a question, so in general practice, CL should be the first choice. And for researchers, we need to investigate further randomized studies, need to investigate the practical advantages over CL, and we need to investigate the medical economic impact. And now we know how to treat endometriosis surgically, so let's explore how to treat with medical pathways. Comparative analysis of medical alleviation interventions to alleviate endometriosis-related pain. It was a systematic review and a network meta-analysis. The background is very similar, of course. Endometriosis affects almost every 10th woman. The symptoms can be very diverse: dysmenorrhea, dyspareunia, dyschezia, and so on and so on. As we know, there's a lot of therapeutic options. In this case, let's focus on medical therapies. We can divide it into two groups: hormonal treatments and non-hormonal treatments. And we need to choose a 6 months follow-up time based on the hormonal treatment side effects. Okay. Here you can see now, let's see the therapeutic options, what we were investigated. The size of the green bubble represents the importance of the given drug type, combined oral contraceptives, gonadotropin-releasing hormone antagonists and agonists, progestins, aromatase inhibitors, selective estrogen receptor modulators, NSAIDs, and opioids, and the combination of these ones. Our clinical question, which is the most effective therapeutic option for endometriosis-related pain? Our population, women of fertile ages with endometriosis. We compared the previously mentioned medical therapies, drug types, and our outcome was the endometriosis-associated pelvic pain. Our hypothesis, combined oral contraceptives, because these are the most widely used, are superior to the other therapies for endometriosis-related pain. And after we finished this process, we could turn this knowledge next to the patient's bedside. We conducted a systematic search in 3 different databases. Here you can see our search numbers. I highlighted to you the 4 big boxes of our search key, and after the process we got 47 eligible full text. The tool seen, we use the tool seen here to measure pain. These includes various pain rating scales. The most widely used, the most commonly used was the visual analog scale, which measures the pain from 0 to 10. And I bring to you several examples from our overall 12 outcomes. These are ranking probability figures, and we gave a number to each investigated drug type from 0 to 1. The 1 is a theoretically best treatment. In my opinion, these separate analyses, separate outcomes, not so interesting than the actual final conclusion, so let's turn to that. In case of this scenario, based on our results, we can recommend GnRH agonist supplemented with oral combined contraceptives. In case of dyspareunia, we can recommend combined oral contraceptives, and in case of overall pelvic pain, combined oral contraceptives, or we can choose progestin combined with aromatase inhibitors. And implication for research and practice. Honestly, dyschezia and dysuria could be the leading symptoms in case of deep infiltrating endometriosis. But we don't find any data regarding these ones, so we need to investigate in the future. We need to carry further randomized studies, and we need to push our limits higher and higher and need to observe longer periods. Yeah, just a quick sum up. As Chandra already mentioned, the first article was published in a Q1 journal, and the second one in a D1 journal. And also he mentioned that we presented our results previously, and on the right corner you can see one of my tutors, Dr. István Szabó, who performed the first robot-assisted surgery at Semmelweis University, and I have the honor to assist him. We started to measure the quality of life at our clinic. We developed an online endometriosis fertility calculator, which does not have existed before. And we created a new patient-centered surgical consent form for endometriosis surgeries. So thank you for your attention, and I would like to help everyone who helped me to get this point where I can stand now. Thank you very much.
Thank you very much, Ádám, and thanks also for keeping the time. So we have a lot of time for questions. And I turn to the 2 obs and gynae experts, the opponents, to challenge you with their questions. Tamás, would you like to start? Okay, then Szabolcs, it's yours.
Thank you very much. First of all, I congratulate to your work. I think you focused on a very controversial area of gynecology, and especially gynecological surgery, because the robotic technique is a new thing, I think, especially in Hungary. And My first question is that did you find any advantage of robot-assisted surgery in advanced endometriosis?
Yeah, thank you for your comment and your question. Of course we find, but we can't find any numerically measured data regarding which are the aspects where the robot can beat the conventional technique. These areas is the comfortable areas. So the surgeon don't need to scrubs in. They just sit in a comfortable position. They don't need to stand in a rigorous position for hours, and it can help the surgeon to feel better and don't be tired and don't be exhausted at the end of the day. And maybe in the future, I would like to emphasize you that in the future we can get better and better results if the surgeon spends more and more time with this newer technique. So the answer is, yeah, there's some area where the robot can beat the conventional technique, but we can't measure it yet. Or some author tried to measure that. They put electrodes on the muscles and measure how the muscles tired, but only one or two authors use that, so we can't use this data as we only describe it in the discussion part of the article.
Thank you. I think you are right, but especially in endometriosis surgery, when the surgeon is standing there for long hours in the operating theater, it can come better results in the operative time and closer the two different gaps, because I think what you mentioned is muscle strength and the exhausting of the surgeon come out better in the conventional laparoscopy. So it's a controversial issue, I think.
Yeah, but my opinion is, or if somebody start with and try a new technique in the early stage, everybody stay very careful and maybe do the things, do the steps more slower. And if somebody is more experienced with the newer technique, I think this distances will goes away, and we will see that difference what we talk about.
And based on your results, have you reconsidered the indications for robotic surgery at your department?
We already did a lot of endometriosis interventions. We did bubble resections, which is the kind of the most hardest procedures. But after we did this, we finished the study, we more focused on that cases where the laparoscopy is not suits very well. For example, high BMI index, or there's a lot of previous surgical intervention, and not only for endometriosis cases. So we make a kind of a turn from endometriosis to other kind of situations, not specific disease, to use the benefits of the robot.
Thank you very much.
Okay, are you ready with the questions? Please, go ahead.
Well, let's start with some comments. So, when you introduce a new, first of all, congratulations to your works and your lecture. When you introduce a new method into the practice, it usually takes longer time. So, probably that is one explanation for the robotic-assisted laparoscopy takes longer time compared to conventional laparoscopy. On the other hand, that is probably even more important, that is the different stage of endometriosis. And I can remember when I was young, in the beginning of 1990s, we started to perform the laparoscopic cholecystectomy. And 4 medical doctors perform one laparoscopic. We start the laparoscopic surgery with, at the surgical department, of course, with the cholecystectomy, because that is an easy intervention. So we were 4 there in the operating theater, and each of us has one forceps or the camera. So, of course, later in time, when the surgeon have more routine, then this time will be shorter. I would like to ask, what is your opinion about that? Recently, maybe it is taken into consideration to perform less invasive surgical intervention, even in case of deep infiltrating endometriosis, and to administer prolonged medical treatment. What is your opinion about that?
Yeah, thank you for your question. Your point of view has highlighted us that endometriosis is very heterogeneous. So there could be very simple if you do an operation, or the situation can be very hard. There could be a lot of adhesions. And during our investigation, we mixed these type of, and the severity of the endometriosis all together. We can't do any subgroups. So, and as I mentioned, so the distribution of the patients was not randomized, because the surgeons know that the newer, the better technique, if I choose that for the patients, for that case, for me, that will be easier, better. And in case of the more easier cases, they said the patients decide that to use the conventional laparoscopy. And it could be kind of things behind that. There's no any difference between the 2 techniques, because they push the patients based on the surgeon's opinion, and that's it. And yeah, in the future, maybe need to be less radical regarding the surgical interventions, and don't do in every case surgical interventions, rather than use some medication. That's why my vision is just find one pill and that's enough. Yeah, I think I answered your question, I hope.
And what is your opinion about pre-interventional medication with combined pill, for example?
In everyday practice, we use that to give some medicines before the operation to, for example, GnRH agonists to get smaller the endometric notches. So we combine the 2 techniques, of course, but we don't investigate that.
As concerned the second half of your presentation, there were different symptoms and different recommendations concerning the medication. However, I'm afraid that patients have not this symptom or that symptom, but altogether many symptoms. So, in conclusion, any patient with different symptoms, what is your recommendation? What kind of medication?
You are right, because in our everyday practice, endometriosis outpatient department, we see that all the symptoms is a big mixture of what you already mentioned. and we can't. It's very, very rare if somebody come in and tell, "Hey, doctor, I only have one certain symptom." But we try to answer this question or help for that kind of patients. I only can say, if you ask me, I tell my own experience at our clinic. We can say now there's a newer drug type which already has been used for fibroids. If I'm correct, I don't say the name of the drug, the medicine. It's Relugolix, so it's GnRH antagonist combined with oral combined contraceptives in one pill, and it seems like a very effective therapy, but we have only one RCT regarding this type of drug what I mentioned now.
Did you find any publication concerning the selective progesterone receptor modulator?
Yeah, but that not every aspect. So I can't find data.
I mean the ulipistral acetate.
Sorry, what?
Ulipistral acetate.
Yes, but it was in a lot of cases in the middle of the in the figure, the ranking probability figure, or at the worst quarter of the ranking probability figure. So these are not the best drug types.
Okay, thank you.
So congratulations for the very nice studies. I would like to ask you, I mean, I saw that 4 out of 12 of your publications were from 2020 and 2021. All the others are older than 2020. Now we have different robotic systems. I know at least for prostate, there is practically only one system that for radical prostatectomy with neurovascular bundle preservation can be recommended and used. So the question is, were there any differences between different robot-assisted systems? And perhaps with longer experience, the results would be better. And then did you look, or could you look maybe in the future only to the difference between endometriomas and the deep pelvic endometriosis and combination? Because probably the results would be different for endometriomas only.
Yeah. Thank you very much. Yeah, at our clinic we use the newer Da Vinci Robot 11, but we did not do any research regarding that or make a subgroup analysis based on what type of robot is the best. So you are right, and in the future maybe we'll better and better robotic tools. It will get better features, so the results will be better and better, but we did not investigate that part, so it could be a problematic part, because yeah, as you mentioned, in the past the robots were absolutely in different shape or features. And yeah, if somebody only did just one certain procedure, just bladder deep infiltrating endometriosis, or just endometriomas, it's better to use the conventional technique because it's the easier procedures, and we need to decide that we only use the robotic technique in case of the serious endometriosis stage 3 or 4.
Any questions from the floor? I know that the carbon dioxide level is really increasing here and the temperature, but still. Well, what are you thinking? You have a question, Peter. Okay, then fire away.
I can't resist to ask the question. No, the AI is improving tremendously, week by week, day by day. So now you were speaking about robot-assisted surgery. When do you think you will speak about surgeon-assisted robot intervention?
Can I ask you another question? Do you let just a robot without a human operate you?
I will look at the randomized clinical trial and look at the outcome of it, and if the robot assist doing better, I would go under the robot.
That's my answer then. So.
My second question would be, it's a more practical one. You had a brilliant network meta-analysis. However, usually during the network meta-analysis, you lose articles because you can't put it in. So how many articles you lost due to the usage of the best methodology? And maybe in the systematic review part of your article, have you seen any important things which might have been possible, you know, to investigate if you use maybe not only randomized clinical trial, but also cohort analysis or the others?
Honestly, only 2 articles were what we need to exclude, and that will be very helpful if you can use them. But yeah, we use a very rigorous standards or criteria. And if we can use all the things, not just RCTs, maybe around 100 article what we can use, so double of what we can use, so double. But the structure and of
have you seen any outcome which would
the outcomes what we can't.
Have you seen any outcome which the other 50 articles would have, you know, been?
Because we excluded them,
Yeah.
I do not see that.
Just for future reference, please don't hold the end of the microphone, just for all of you. Otherwise we will go deaf at the end and we will need the ENT experts to make us better. Any other questions? Well, I have one. Oh, there is one. Gergely.
Maybe it's a little bit follow-up question to Dr. Hegyi's question, that do these robots record your actions, and do you think that there would be some way to analyze these operations?
Yeah, these kind of the newer generation of the robots, the generation 4 Da Vinci robots, measures and records not just video, then the mistakes, or if we learn that what we call a mistake, it can measure, and after the end of the procedure, the operation, it will write you down that how many times you don't handle very well the equipment, you hold it too long, or you felt the structure, the needle, for example. So yeah, it can measure your things, what you do.
Have you come across any studies analyzing these data which were collected?
No, because if I know it correctly, they don't report it yet, because only the newer generation record this. So there are, in the literature, we did not find any data regarding this, but it can measure. Maybe in the future, they will report them.
Perhaps you could also use it for training future surgeons?
For training?
Yes, like
of course,
there are pilots.
Yeah,
things.
there are kind of games to train yourself. There are a lot of games to measure, and the robot measures how many, as I mentioned, the mistakes.
Because I think it would be great if we could use these robots to quantify the performance of the surgeon as well. So
it measures that.
Okay, thank you.
We have plenty of time for more questions. But now I'm going to ask mine, right? So, Adam, it seems to me that you like robotic surgery, don't you?
Yeah.
I thought that, yeah. So, in this case, I mean, you have presented us data on retrospective studies mainly, with high heterogeneity and high or moderate risk of bias, each and every single study. And then you concluded in your title that robotic surgery doesn't have any demonstrable effect. So, I mean, you're slagging off something that you like, and you don't really have the evidence behind it. So my question goes, okay, I accept that this sells the paper very well. But if you would like to show in the future that really robotic surgery is superior or not to conventional laparoscopy, what would be your plan regarding the design of that study to eliminate all the shortcomings that you learned from your meta-analysis?
I think it's almost the same what already happened in the past when we changed from laparotomy to laparoscopy, and almost the same. And that will be the key. Maybe my generation will see from the earliest stage of my career this technique, and I saw my tutor how he performs everything, and maybe this will be the key. Only this will be enough I see a lot of cases, and after when I will reach that point that I can use that robot, because now I only assist. Maybe my generation will better and better with this technique. And the other part of the question was regarding
how to design
a clinical
trial.
I don't know, but I didn't think about that yet. What we do now is, I didn't put on my slides but we collect all the data, all these perioperative data at our clinics. So maybe our numbers will be different from what they measured in 2010s years. But I don't think about that yet. What will be the key to put it so we don't need to measure that rather than we need to measure that? That was your question, isn't it? Yeah. More or less.
Okay. So it's hard to predict, especially about future, as Mark Twain said. But I think that probably your next academic degree, I mean the Master of Sciences, will about the robotic assisted laparoscopy is much more better compared to conventional laparoscopy.
Yeah, maybe. That would be good.
Any other questions? Please grab a microphone, but not at the end.
Congratulations. So you mentioned the calculator. What did you use to make that calculator to calculate the fertility with endometriosis?
Yeah, thank you. It's not in connection with our actual research. It's just absolutely different way. It's just predict to a patient who underwent endometriosis surgery how many percentage you have, and it's an estimation to get pregnant without any IVF technique. It's based on an already published article, but it's just A4 paper and in English language, and we did an online form, so it's more easier for the patients. That's it.
Can you tell us, are there any guidelines regarding this? When should one use robot-assisted laparoscopy for endometriosis?
Yeah, I'm looking for that, and I discussed it in our article. And for example, the American Society recommend the same. At this time, you need to choose firstly the conventional technique.
And what is the level of evidence behind that? Do you remember?
I don't know.
Usually they say whether it's a strong or weak recommendation supported by.
It wasn't strong, if I remember correctly.
Right. Now, my last question regarding costs.
we're looking. It could be the most interesting part of this study, but we did not find any data. In general, robot-assisted technique, there are already reported numbers, but specific for endometriosis, we did not find any data. Because
is it more expensive?
More expensive. Yeah.
More expensive.
It's more expensive, so it's a little bit a sneaky part of it. So if we do it, if we do the same in the past as the laparoscopy connection, we won't stand here maybe. So need to investigate in the future. I think that, because if you think about the healthcare only economy related, it won't lead us to a good way. That's my opinion.
Okay, any other questions, comments from the panel? You happy? In this case, we close this part. Thank you very much.
Thank you very much.
Yes, and because we are very good at time, I suggest to have a committee meeting, and after we will come back with the result.
I would like to ask everybody to stand up, and it's a great pleasure to announce another successful PhD defense. So Ádám has defended his PhD with an excellent 97% result. So congratulations, and to you and your supervisor.